I get asked a lot of questions as a surgeon about wound healing in dogs and in cats. And in particular, I'm frequently asked about the differences between wound healing in dogs and cats and if they should be treated differently or thought to be different. And there is an assumption that wound healing is a relatively homogeneous process across species lines, but cats and dogs have very different healing processes. And although this is an old paper from 2004, it's the only paper that's really taken a look at these differences between dogs and cats throughout the phases of both open wound healing and incisional tension strength between dogs and cats at different times. So we'll go through this paper and cover quite a bit of things about wound healing in our patients in small animal. And I think the paper really did a good job demonstrating that cats have significant qualitative and quantitative differences in cutaneous wound healing when compared with dogs. These differences really seem to predispose cats to certain clinical wound healing problems. I'd say in particular, we have noted that large open wounds in cats in general appear to heal more slowly than do similar sized wounds in dogs. There's noticeably less granulation tissue formation in the wound, particularly in those early stages of wound healing. And we know what a healthy granulation bed looks like and how quickly that can form in a healthy wound in a dog, and how frustrating we can get with what appears to be delayed wound healing in cats. And it's probably not delayed wound healing, it's probably normal wound healing in cats, and we just have to be patient because things do take a lot longer. When we look at all of the reasons why, the phases of an open wound that's healing, we go through the granulation tissue and contraction and epithelialization. There is this also sense of false healing in cats, where when we're referring to a closed incision, this phenomenon that we've referred to as false healing of sutured cutaneous wounds has also been noted that in cats, we've seen this more frequently than we see it in dogs. The wound appears to be healed from superficial observation, but when the skin sutures are removed, there's complete dehiscence as soon as the animal applies stress to the wound through some version of normal motion, running up and down the stairs, darting out of the room. And if you haven't experienced this in cats, you're lucky. I know that I have experienced it. And in these cats, we're taking sutures out at 10 to 14 days post-op, just like we've been taught. I'll tell you that we may be more appropriate to lean on that 14 to 21 days potentially for wound healing in cats if we're going to be removing skin sutures, if we're relying on those skin sutures for keeping the wound together. Some of us put skin sutures in just to hold the skin together. We put in a nice intradermal layer. In those cases, I'd feel comfortable taking those stitches out at 10 to 14 days. So it's interesting when we look at these different wounds. There's a cat wound here on the top as it's going through its healing process, and then a dog wound on the bottom. And you can see that the beginning photos are similar and these ending photos here are similar, but the time that it takes to get there in dogs and cats is very different. And when we look at why that is, there's a lot of reasons, but cutaneous wounds in cats do heal more slowly. There's a less exuberant inflammatory phase and a less early granulation tissue formation. And the differences in wound healing between cats and dogs is probably due to differences in their cutaneous blood supply during the healing process. We know that dogs have this really well-distributed cutaneous perforating vessels all over their body. So dogs have this robust blood supply to all areas of the skin. And if we look at the difference in cats, cats have a much smaller number of cutaneous perforating vessels, and they're more widely distributed along two major lines of the actual trunk. So we don't have as diffuse, if you will, of a vascular supply to the skin in cats as we do in dogs. And that's probably one of the bigger reasons that we see these differences in healing. In general, when we look at the paper that was done, there is significant differences that were noted in the healing of open wounds, cats lagging behind dogs in percentage of epithelialization and percentage total wound healing throughout a 21-day period. So it's not just granulation tissue formation, but it's also epithelialization. There were significant differences between cats and dogs in both temporal and spatial distribution of granulation tissue. Dogs, as we know, as we're used to seeing, they granulate starting at the bottom of a wound, and they cover the entire bottom surface of the wound, usually by the 7th day, if it's a healthy wound. And so this picture on the bottom here, we get this really nice granulation tissue bed forming in really a relatively short period of time, around 7 days. But in cats, that amount of early granulation tissue is significantly less, and it distributes differently in the wound. So it first appears at the cut edges of the skin, and it then tends to spread to the central portion of the wound, and it does this fairly slowly. This difference really is the reason why we think these wounds contract differently as well. And there are different theories of wound contraction that have been proposed. There's the picture frame theory, and this theory of wound contraction states that these myofibroblasts that are in this granulation tissue that are really located at the edges of an open wound are responsible for the centripetal forces that lead to wound contraction. And this is really what we see most likely in the cat. On the other hand, if we look at dogs, we have a pull theory. So picture frame theory in cats, kind of a pull theory in dogs, where these myofibroblasts that exist throughout all the granulation tissue generate forces responsible for contraction. And it's really a model that really looks at dogs that have this abundant early granulation tissue bed, and the reason why we see early contraction in dogs as well, just like unlike what we see in cats. So this picture frame theory of wound contraction that we see in cats is really where we see that early granulation tissue form around the edges of a wound and then slowly fill in the middle. And when we looked at, when this group of authors looked at the incision strength, there was a significant difference in the breaking strength of sutured skin wounds at 7 days between cats and dogs. So dogs basically had double the amount of breaking strength of sutured skin at 7 days compared to cats. Cats eventually got there, but it took them a lot longer to get there than it does in dogs. And this is probably a difference in the production and maturation of wound collagen, and it proceeds at a much slower rate in cats than in dogs. So it's just the idea that cats do heal more slowly, and I think we have to be more patient with cats. For closed incisions, it may be wise to consider pushing their suture removal out to that 14-day mark, maybe longer in some cases, especially as these cats get older and are having surgeries performed for other reasons besides their spays. And really understanding when we're dealing with an open wound in a cat that it may not be so much that things are delayed as they are just taking slower, and to be more patient and prepare the pet owner for that too, that these things aren't going to be healed in 14 days or in 20 days. It takes a lot longer in cats for these wounds to heal by second intention wound healing. So I want to talk a little bit about tissue intelligence. And this really is in regards to open wound management. This has nothing to do with closing primary incisions and the intelligence that tissue actually has on whether or not it's going to heal, despite what we do or don't do. And our real job when we're dealing with open wounds is to remove the obstacles to healing. We want to make sure we don't add more obstacles. And there's plenty of creams and lotions and detergents and sprays that actually add obstacles to a wound from inhibiting its ability to heal. So our main job is to remove obstacles and not create new ones. And there's always a biologic basis for why a wound won't heal. And I'll tell you the most common thing that I see is the presence of necrotic, devitalized and or infected tissue still in the wound bed. It will keep the wound stuck in the acute inflammatory phase, which normally is early in the process. It's usually the first few days. The inflammatory cells come in and start cleaning up the wound, and then granulation tissue starts to get laid down. That granulation tissue bed will never form, or at least if it does form, it's going to be very pale, maybe even grayish yellow, and not really progress beyond that if we've got devitalized, contaminated tissue still in the wound. If there's foreign material still stuck in the wound, we'll be stuck in this acute inflammatory phase. We'll never go on to proliferation. We'll never go on to remodeling and maturation and collagen accumulation. And so we have to be careful that we're not looking at wounds in a light that we are a little bit reserved in our debridement. And we'll talk about debridement in a little bit. This is a great example of an obstacle, and I know that a long time ago in some veterinary schools, eschars, these blackened, dead layers of superficial skin were thought to be useful for healing for the underneath tissues, and so it was recommended that these eschars remain in place. And we know that not to be the case. Again, It's adding a source of acute inflammation to the wound. That wound's going to have a very hard time going on to mature and going through its wound healing phases of contraction and epithelialization if we've got dead or devitalized tissue still in place. So let's dive into open wound management and the different ways that we can approach these wounds. The one thing I will say is if you're debating whether or not you should close a wound or leave it open for open wound management, I would absolutely leave it open. You just get rid of the debate in your head, because an open wound can't dehiss and it can't form an abscess. And so an open wound is one of the best ways to deal with those cases that may have latent devitalized tissue formation. A bite wound is a great example, crushing injury. Those tissues may not be dead at presentation at the time of our decision making and whether we're going to open or leave the wound open or close it. But in 3 days, that tissue may be dead. And if we had closed the incision, we're going to have a major dehiscence and likely infection. So if you're doubting it at all, or if it's a dirty wound, a wound that has been around on that patient for more than 6 to 8 hours, then we may want to consider leaving it open. And it doesn't mean we have to leave it open for the entirety of its healing process. Delayed primary closure is probably the most underutilized form of wound healing and probably one of the smartest forms, where we would leave the wound open for a day or two, let the tissues declare themselves, clean everything out one more time, and then go ahead and close it. Delayed primary healing is a great way to be successful with wound management. So we want to make sure we have an appropriate clip and prep around the wound. The fur is very dirty, and no matter how good we are at scrubbing even skin that is devoid of fur, about 30% of skin bacteria still remain in the hair and fur follicles in our patients after a good povidone iodine or chlorhexidine and alcohol mixture prep. So we really want to get rid of as much fur as possible. And then we consider wound debridement at that point. And I always start at the superficial aspect of the wound and work my way towards the center of the wound with debridement. And then I start superficial on the wound layer and work my way deep down as we progress through the wound debridement phase. Anything that looks questionable, I remove. And it may mean that your wound is getting bigger and bigger before your eyes. But if we leave devitalized contaminated tissue, we are going to wind up with a massive wound that has to be debrided and potentially closed at some point. And then we move on from debridement to the lavage phase. In general, sometimes we lavage first because of gross contamination. Oftentimes we're debriding and then doing a final lavage. And we'll talk about with what and how much and the different techniques. First of all, copious amounts. Dilution is the solution to pollution. I think we all heard that in vet school from the surgeons, and it's the truth. So some people are in the pressure camp where they try to generate 8 to 9 pounds per square inch of pressure with saline or LRS at the wound bed. I'm more of a volume guy. I'd rather just put large volumes of fluids through these wounds to dilute them out and not worry so much about pressure. Ideally, we're using a sterile isotonic balance solution, but I'll tell you that in my own practice, I'm mostly using sodium chloride, 0.9%, which doesn't fit all of these recommendations, but works really well. And then, should we put antiseptics in the lavage solution? I know a lot of us do. I would say early on in wound management, that's appropriate. Using wound antiseptics long-term in our lavage solution can actually inhibit the wound healing process and inhibit those fibroblasts from coming in. I get asked questions a lot about tap water. And I would say for really large wounds early on in their presentation, incredibly contaminated wounds, tap water is the way to go. Tap water is hypotonic, and using it every day on a wound will delay wound healing and cause tissue destruction. But if you're doing it in the initial presentation, or even the second day, because the wound is so massive and or because it's so contaminated, there's nothing wrong with using tap water. And in fact, these hose sprayers connected to our wet sinks are great. When there's this much contamination in a wound, we really need something like tap water, just an abundant source of fluid to remove as much of this debris as possible. So it's okay to use tap water, just use it early on. It will cause tissue destruction and inhibit wound healing if we're using it every day, though. So you're going to want to switch over to something like sodium chloride or a Ringer solution. This is just an example of putting an antiseptic into a wound lavage. If you're going to use anything, I would use a 0.05% chlorhexidine dilution over povidone iodine. Povidone iodine in open wounds tends to cause more fibroblast destruction and inhibition than chlorhexidine does. So if you're going to use anything, I prefer that we use chlorhexidine. And this is just one of many ways that I would lavage a wound. These are these nice liter bottles, and taking an 18 gauge or a 19 gauge needle and poking some holes in the top, and then you've got a decent amount of pressure, not 8 to 9 psi, but you can put a lot of volume through these wounds very easily this way. Some of us like to set up with a liter saline or lactated Ringer's bag of fluids and an IV extension line hooked up through a 3-way stopcock and a syringe and a large bore catheter or needle. This is utilized more for generating those 8 to 9 psi's at the tissue level, and also putting large volumes through fluid. So there's no right or wrong here. Lots of ways to flush a wound, and just do with what you're most comfortable with and enjoy using. We really don't want to put any detergents, obviously no hydrogen peroxide, no topical antibiotics or liquid antibiotics into these open wounds. All of these things are going to cause tissue destruction. And the main way to deal with getting rid of bacterial contamination is truly through our lavage and through our debridement. And if we do a good job at those two and we remove those obstacles, the body's going to be able to do the rest. I do recommend culturing open wounds, and the question is what, when, where, and how. I do my culture after I have done my debridement and my lavage, because although it's interesting to see what bacteria are in a wound when that patient presents to you with all of its debris and contaminants in the wound, it's not what's going to be left in the wound after you're done with debridement and lavage. So what I really want to know is what bacteria are left in the wound after I do all of my hard work that I'm going to need to treat with antibiotics. So that's why I culture after my debridement and after my lavage. I want to know what's left in those tissues. And then open wound management, we'll go through a couple of concepts that I think are catching a lot of traction now in veterinary medicine, which is great. There's a concept of an ideal dressing. There is no such thing, but we can get pretty close with some of the dressings that are available nowadays. But traditional wound management we have to talk about first, and this is where we'd have an open wound. We would debride it, we'd lavage it, and then we would do some sort of a wet to dry bandage and continue with mechanical debridement through the wet to dry bandage. But in what we're doing is creating, even though it's called a wet to dry, it actually becomes a very dry bandage. It becomes desiccated, it becomes sticky to the wound, so that when you peel it off, you're peeling off not only the bad stuff, but the good stuff too, the good cytokines and growth factors and fibroblasts and granulation tissue. So there's a difference here between wet wound healing and dry wound healing. And what we know today is that we really want a wet wound environment. And this is an example of a wet to dry, very effective at removing debris and removing some minor devitalized tissue from a wound, but it is removing all of the important things that we need for wound healing. So there are better ways to get that nasty stuff out of the wound without subtracting all of the really important factors for wound healing, including our early granulation bed, which comes off when we're removing these wet to dry bandages. So we really want to focus on moist wound healing and keeping that wound moist. And in fact, what's been shown is that maybe counterintuitive, but in a dry wound bandage situation where the tissues are becoming desiccated, the predominance of bacterial overgrowth and infection happens a lot faster than in a wound that is kept moist. And a lot of that has to do with the functioning of the inflammatory cells in a wet versus dry environment. The one thing we know about moist wound healing and what we call our moisture retentive dressings is that they decrease pain during bandage changes. In fact, very infrequently do we have to sedate these patients to change these bandages. The material that we're placing on the wounds don't adhere to the tissues. They're not sticky. They're not creating a bridge or a bond with the deeper tissues, so it's much less uncomfortable to change. We can minimize our dressing changes, doing them relatively infrequently, even early on in the wound healing, and we can provide some autolytic debridement at the same time. And so moisture retentive dressing, some examples. These aren't, this isn't an all-inclusive list, but foams, hydrogels, alginates are all examples of these types of dressings. And we'll just go through a couple of them. And regardless of how amazing a rep may make some wound healing products sound, whether they're foams, alginates, hydrogels, sprays, creams, lotions, none of it replaces good surgical debridement and lavage. We just don't have anything that comes even close. Because remember, our whole goal is to remove obstacles. Wounds are really good, tissues are really intelligent, and will heal on their own without doing much more than just nice debridement and lavage. So there are a lot of advantages of moisture retentive dressings, very similar to what the ideal wound dressing would look like. We can maintain this ideal wound environment, having enough moisture without maceration of the tissues. And with that, we get this higher concentration of growth factors, a promotion of epithelialization and fibroplasia, so we'll get more wound contraction, less frequent changes, less adherent, therefore less painful, and in some cases hemostatic. So let's start with foams. Open cell polyurethane, it's highly absorbent. So you're going to be using this in your moderately exudating wounds. You can use them in your light exudation wounds as well, but light to moderate, I would say. And these foams are great because they're going to be, by wicking the liquid or fluid, the exudate out of the wound, are going to be bringing some of that debris and bringing some of that bacteria with it and storing it in the foam away from the wound, all the while keeping the wound at a relatively high humidity level. They're very comfortable to wear. They can be left on for several days, even if it's the very first time you're applying the bandage and it's a pretty large open wound. I'll probably keep it on for 3 days for that first bandage change before I go ahead and change it. Just have to be really careful in highly exudative wounds or wounds that you're suspicious are going to be highly exudative. You can saturate the foam sponge, and if you leave it on for too long, you will get maceration, which really just winds up being as bad as desiccation does with our dry bandage techniques. Alginates are probably my favorite, most versatile type of contact layer for moisture retentive wound healing. It's produced from seaweed. What I love about it is it forms this nice hydrophilic gel on the wound surface. So it absorbs all the wound debris and exudate, just getting it away from the wound, which is what we want. But in the process of doing that, it forms a hydrophilic gel, a coating on the wound, and it's very easily removed by irrigation. So sometimes when you're changing your alginate dressings, the wound looks terrible all of a sudden. It's brown and gray and gooey, and all that is the alginate doing its job. And so just lavaging that or wiping that off will leave this nice granulation bed underneath. And then hydrogels, I find hydrogels, again, another useful kind of tool to have in the toolbox when we're working with open wounds. I tend to use this more in wounds that are not as exudative and wounds that have kind of stalled a little bit. They've got a great granulation bed, but really have not done much in the way of epithelialization and contraction. And I find the hydrogel kicks a lot of these wounds into a higher gear, and it creates a very moist environment. They are occlusive, so you have to be careful in the wounds that you're using them in. You don't want to use them in too exudative of a wound. I usually don't use them early on in the wound healing process. It's usually after that first week if I'm trying to get this wound to completely contract down and epithelialize. But hydrogels are very effective for speeding the process up and getting a lot of those cytokines that we want and growth factors that we want to proliferate in that wound and create that epithelialization and contraction that we all like to see. I always get asked about honey, and I would say if you're going to use honey, I would use it in a combination with these types of dressings that we just discussed, and there's some professional products out there that do combine it. I will say if you're going to use honey at all, to make sure that you're using honey that is generated from pollen from the Leptospermum species or genus of plants, and that's going to create a Manuka factor based honey. Now, a lot of honey is sold as having active Manuka honey in it, and you're going to wind up wasting a lot of money. You want to make sure it's a brand you trust that has a high level of unique Manuka factor in it. And what I do instead is I actually just buy the medical grade, medical device like types of unique Manuka factor honey called Medi Honey. There's also a version of this where it's infused into an alginate or infused into a hydrogel like gel, and I find these to be very useful in early wound management. For those of you that enjoy using honey or are curious about using it, this creates a much more controllable situation too. It's not as messy and not as sticky, and you're not dealing with as much of a problem as you sometimes can with honey. So back to this picture, just again, remembering there is a big difference in wound healing between cats and dogs. Cats do take a lot longer to heal their open wounds, and the tensile strength of a closed wound also matures more slowly in a cat than in a dog. So just good things to remember when we're dealing with cat incisions versus dog incisions and dealing with open wounds in cats versus open wounds in dogs. Be patient with the kitties because once they get out to about that 20-day mark, they really start to move fast and start contracting very quickly, but it takes them a while to get there. Hope everybody enjoyed that. There's a couple of true and false questions if you're interested in testing your knowledge, and we'll see you at the next Journal Club. Take care.